Good afternoon, everybody. It's Friday, the 1st of December. You're here at Lunch and Learn. With us today is Ruben Perez. Ruben, I met Ruben when he was working with ISNR on the board of directors, and he's going to be talking today about neurofeedback efficacy and motivational reinforcers. I think he did a paper on this. So without giving you any more details, he'll give you whatever background he would like to give you. Ruben, thank you so much for being with us over there in Spain, and we're ready to rock and roll. Thank you.
Thank you very much, Rob. Thank you very much, Dr. Sauter, and thank you very much, Rob, for this invitation. For me, I'm feel so honored. One of the reasons is that I talk. Sorry for my English. My English is awful, but I will try all my best, and and I will ask you to, if you have some questions, to speak super slowly for me to understand. And okay, one of the reason I feel super honored is that I talk one of the new main academic courses for my BCIA accreditation. So I feel super. For me, you both guys are superstars. So I'm feeling super honored. Okay, I will try to spawn some insights about why we always see how neurofeedback is effective for different pathologies or different conditions, but we also have to focus on why neurofeedback doesn't get show its efficacy when we run studies. And most of the studies trying to show the neurofeedback efficacy for different conditions come from universities, and I think this is a problem. The studies come from academics and now from clinicians. Most of the times, it is not. It is just a generalization, but and sometimes researchers get different technical problems. I think I will call it technical problems. I mean methodological problems in the sense in terms of the use of neurofeedback. Trying to control variables, they misuse neurofeedback, and then the results are sometimes not what they or we expect. So although the efficacy of neurofeedback techniques has been extensively demonstrated over the years in a wide range of conditions, there are several questions regarding their efficacy or their limitation when we compare it with other techniques, therapies, or treatments. And I will discuss some of these issues. Well, I think that one of the first thing to point in the case of the neurofeedback efficacy is that many studies are focused on analyzing the efficacy of neurofeedback by pathology or by protocol. So I will go deeper in that later, but when I review the literature, I find that most of the studies trying to analyze the neurofeedback efficacy do it by pathology or protocol. There is also another question, that it is that there is a strong contradiction between the effect that we can find in case studies or series studies, case series versus group studies. In the first, we can find good results, but in the later, sometimes it is not what we are expecting. And in the end, we can find also some issues about not taking into account several factors that could modulate the neurofeedback response. okay, the idea that neurofeedback can be effective to treat different conditions arise from the fact that we can modify abnormal electroencephalographic patterns associated with these pathologies. So we have, I know that it is simple for you because you are very related with the field, but we have a patient who have a condition, and this patient have also a deregulate brain activity, and then we can modulate this brain activity through neurofeedback, and then we can bring back this patient or client into toward a more normal or more normative or more adaptive brain activity pattern. So if we consider neurofeedback as a operant conditioning technique, and I think it is a assumption that it is widely accepted, the aim of the quantification of the EEG is to convert the EEG signal into numbers, into values, and these values will be the variable that we want to modify through neurofeedback. So our target behavior in a microscopic approach are not thoughts, feelings, behaviors in a phenomenological in their phenomenological aspect. Our microscopic target is EEG. So we have a macroscopic approach. We need to improve the health of our patients, and it involves a lot of, I think, a lot of intervention or approaches. But when we are talking about neurofeedback, we need, first of all, we need to change the brain pattern. So, and that's why I think that when studies approach to do research about neurofeedback efficacy, sometimes they fail, because in psychophysiological studies in which the physiological variable is measured, and it is assumed that this physiological variable is is a function of cognitive or psychological variable. When we do a psychophysiological study in which the physiological variable is manipulated, we assume that the manipulation of this variable will produce changes in the psychological, cognitive, emotional, or whatever variable. And to find biomarkers in the EEG, we need a double direction, bidirectional. We need this bidirectional relationship between physiological and psychological or cognitive. When I say psychological, I mean cognitive, emotional, and so on, variable. And it is not always true, because sometimes a psychological domain is related with a physiological domain, but sometimes also the psychological domain is related with more than one physiological domain. And other times, the opposite occurs, and more than one psychological domain is related with just a physiological domain, and sometimes a lot of psychological domains are related with a lot of physiological domains. So we don't have univocous, I'm not sure if in English it is the word, but we don't have a perfect relationship between physiological, cognitive, or performance and physiological. In this case, here I present 4 brain maps using this Neurogate, but it could be other normative database. 4 patients from our clinic who have ADHD. and everyone has a different pattern of brain activity. Okay, they meet in one aspect. All of them have some frontal implication, but all of them are different. And one pathology and different brain patterns. And we have also the opposite. We have different pathologies with the same EEG or QEEG signature. So the analysis of efficacy by protocol using one-size-fits-all approach is confusing because it overlooks the fact that the target behavior of neurofeedback is EEG, and which can display different patterns or phenotypes depending on the pathology. And the same pathology could show more than one associated EEG phenotype. In addition, these studies I'm talking about, coming from the university, often pose important methodological deficiencies. I'm not mean here methodological in the sense of methodology of research methodology. Is the opposite. Is methodological deficiencies in terms of using neurofeedback. Then, most studies on the efficacy of neurofeedback agree on classifying patient by pathology, but the heterogeneity of EEG pattern makes the study by pathology confusing. The effectiveness of neurofeedback should be verified in the first instance by its ability to produce change in the target behavior, and the target behavior in neurofeedback is QEEG. And there are just few studies that investigate purpose EEG pattern to verify these changes. For example, this is an interesting study using neurofeedback with ADHD adult patients, and they here used the standard protocol for ADHD with the theta-beta ratio to reduce. The aim of this neurofeedback protocol here was to reduce theta-beta activity, theta-beta ratio, but they use the same. For example, they use the same reinforcers for every participant, and they say they did that. They did that way because they wanted to control the procedure to make it replicable. So they use the same reinforcer rate, the same reinforcer for every participant, but what this is a reinforcer for a participant could be no reinforcer for other one, because everyone like different things, but they use the same here. The main measure to evaluate the change was the Conner's inventory, Conner's questionnaire, I don't know. And they, of course, measured the theta-beta ratio, but they did it once the groups had already been formed. So they didn't use the theta-beta ratio to create the groups. For example, it would be interesting to create the groups attending to if they had a high theta-to-beta ratio or a low theta-to-beta ratio or something like that. But no, they use the Conner's inventory. They use the diagnosis of the patient, the clinical diagnosis, ADHD, and they create 3 groups. One of them was, for one of them, they used neurofeedback, theta-to-beta ratio protocol. For the other one, they used cognitive behavioral therapy, and for the last one, they used placebo. And look at that. They measured the theta-beta ratio, but the theta-beta ratio for all of them was 1.11, 1.2, 1.1. So if you go to the paper by Monastra, I know that the Monastra ratio is a little bit more complex, but they use in some sense the theta to beta ratio. They say that the mean of theta beta ratio for adults is 1.4, and our participants had less than 1.4. And they say that to be 2 standard deviation from the mean, being an adult, you need 2.34 in value in the theta to beta ratio. Okay. This is a problem because they are trying to control everything, feedback, theta to beta ratio, changes after the procedure, the treatment, and so on. But they have a starting point in a normal theta to beta ratio. So, what do you want to get if you are trying to treat something that it is already normal? So, and this is because they classify the patients using just the clinical label. The other point is the strong contradiction between the effects found in the case studies and the group studies. And there are, I think, when I put it into my doctoral dissertation, and I find that, for example, there is a lack of standardized protocols, and individualization is a key, but the different studies are run following the idea that the researchers has about neurofeedback, and not. I sorry for insist in that, but sometimes from the university, I have several colleagues at the university who run experiments with neurofeedback, but they are not super trained in neurofeedback. So it's difficult to do that. Imagine to be a surgeon, but you don't have training in surgery. So and when you use a one size fits all protocol, you can have problems because you are not you don't have individualization, and individualization here is a problem. Is a key because there are several fields where individualization is a key. For example, aphasiology, education, psychotherapy, neurorehabilitation, and we need standardized protocols, but for every kind of brain pattern, I think. And for this reason, QEEG is one of the keys for this individualization. Is individualization inside of standardization. The solution, I think, could be the creation of a taxonomy that classifies the patient by neuropsychophysiological factors and not just by clinical label. For example, we can run a study on efficacy of neurofeedback reducing depression symptoms, but we will just keep patients with depression, but with a certain QEEG pattern. For example, frontal alpha, excessive frontal alpha, but not other depressive patients with other QEEG pattern. So creating this taxonomy could work in proving or in testing the neurofeedback efficacy, because you have, of course, the pathology, but you have also the target behavior of this method of behavior modification that it is neurofeedback. For example, we can include protocols in a study to reduce frontal alpha, and doesn't matter if the patient has ADHD or depression, or you can include in your study ADHD patient, but just with theta to beta ratio elevated in the frontal pole, or ADHD patient with frontal alpha. In this case, we would have different protocols for different taxons of this pathology. For example, protocol 1 is just for the taxon A in the pathology ADHD, or the protocol 3 is just for the taxon C in ADHD. There is also a lack of consensus on the number of sessions, and some of the studies use a fixed number of sessions. Other studies use variable number of sessions, considering the result in questionnaires and in question that you made to the patient. And the problem here could be the overtraining. Strel in 2014 published a paper talking about different factors affecting neurofeedback results, and one of them is overtraining. If you imagine you have excessive theta in the frontal pole of the patient and you reduce it, but you are not, you don't have clear how many sessions you will run, and your starting point is a patient with excessive theta activity, but after 100 sessions, I don't know, I'm joking, but as 100 sessions, you have a patient who has deficit of theta activity in the frontal pole. So the patient will manifest frontal pole symptoms in both cases, excessive or deficit. Frontal pole, because it's in the frontal pole where the problem is, but you start with excessive activity, and you have now reduced activity. So overtraining could happen in a neurofeedback setting, and we need a way to decide the number of sessions, or a way to monitorize. I know you do it. I'm talking about in general landscape, but we need a method to control it, and it could be one of the problems when we run neurofeedback studies. And there is also some issues that are not taken into account when we are and when we are studying neurofeedback responses, and they could modulate the response to neurofeedback. For example, feedback signal reinforcers should be motivating for the client. The relevance or motivational value of the reinforcements is important, and there are several papers showing that in the context of operant conditioning or behavior modification. Some time ago, I published a paper, and when the reviewers sent me their contributions, one of them, it was in, I think, 2019, I published something about C-score training in insomnia, and in the methods, I said that I used high motivational value reinforcers for the patient. This patient chose the reinforcers he wanted to use because high level motivational value reinforcers produce higher response takes. And the reviewer told me, okay, it makes sense, but no one published it, and there is not an evidence that what you are saying is true. So you should remove this part from your text, your manuscript. And I did, but I thought I need to try to know if what I'm thinking and what everyone thinks about the reinforcers is true. So I will run a study, and I will tell you later. But this was the German. This was when my idea about to run a study using high level or high motivational value reinforcer versus low motivational value reinforcers study was. And there is also another issue that it is brain-computer interface illiteracy, and it is found in the 15% of population. They cannot modify their EEG through brain-computer interfaces. So what about if we can, or we have a method to detect who is one of these subjects, a subject who cannot modify his or her brain activity pattern through neurofeedback. So finding these markers that differentiate subjects who will respond to neurofeedback from those who will not is interesting, because we can predict before starting the treatment. And another issue that sometimes is not taken into account is the number of criteria to work on. Rogala at college published an interesting paper about neurofeedback efficacy factors in 2016, and they state that higher the number of criteria, higher the number of the factors you are trying to modify with neurofeedback, lower is the rate of response. So it could be interesting to research on this direction. And there is also variables like psychological or biological variables that could influence in the neurofeedback response, like locus of control, multiple diagnoses, pharmacological treatments, and so on. I know all of us know it super good, because I followed for years. I followed the meetings of New Mind Academy and Rob and Dr. Sotter presentations, and we know it, but we need to do research on this direction. I will focus on these two factors and finding markers that differentiate subjects who will respond to neurofeedback from those who will not. Okay. When I was thinking about that, I found several papers showing that slow individual alpha peak frequency could be considered as a non-specific predictor of non-response to treatment, and in a wide sense, because I found a paper showing how a slow individual alpha peak frequency could predict the non-response to medication, to pharmacological treatment in depressive patients, also in ADHD patients, but also found papers talking about no responses in patients who have a slow individual alpha peak frequency to neuromodulation through transcranial magnetic stimulation. For example, in this paper by Arns, they found it. Slow individual alpha peak frequency is associated with no response to several treatments such as stimulant medication, antidepressant medication, antipsychotic medication, and slow individual alpha peak frequency could be considered then a non-specific predictor for non-response. And there is several papers by other authors with this finding no response slow individual alpha peak frequency, and no response to different techniques of treatment. So following this idea, I applied it to neurofeedback in a study, and we they were children with learning disabilities, and we use C-score training. We run the EEG, we detect the subject who had a slow individual alpha peak frequency. We also applied the cognitive and emotional checklist from New Mind Academy, and we separate in two groups: the normal individual alpha peak frequency and the low individual alpha peak frequency. And we analyzed the results after the treatment. And the results were that the patient who had a normal individual alpha peak frequency, when I say normal, I mean an individual alpha peak frequency adjusted by age, and just the group with a normal individual alpha peak frequency changed the brain pattern, and they were also less, they had a lower tendency to move scores that was in the normal range after the treatment, before the treatment, outside of the normal range after the treatment. So it seems to be that when you have a normal individual alpha peak frequency, you have a better response to neurofeedback, in this case using C-score training. And you can see also here the clinical results using cognitive and emotional checklist, and you have here in the dotted line the response of the patient with normal individual alpha peak frequency. It was a higher response that reducing symptoms than those who had low individual alpha peak frequency. So it is interesting. It's interesting to use it like a marker of response. They are the conclusion, but I already said it. But we, based on our data, we can consider that the subjects with low individual alpha peak frequency are not optimal responders to neurofeedback. So our main finding was that the potential use of individual alpha peak frequency as a useful biomarker to differentiate between optimal, I will not say no responder, but optimal and no optimal responder to neurofeedback, but in this case is neurofeedback based on C-score training. Okay, and what about the motivational reinforcers? There is a, sorry, this is in Spanish, I didn't realize, informative value and motivational value. There is two approaches about reinforcers or feedback in operant conditioning, and it is that for humans, the reinforcement has to have informative value. It means that the reinforcers, the feedback has to inform the patient that he or she is getting or not getting the target. And the other approach is the motivational value. It is similar to animal conditioning, because you need signals that motivate the client to repeat the behavior. So my philosophy here is that reinforcers must, in fact, be reinforcers. They must have value for the subject. I remember a friend that was training a woman who had anxiety, and he was using a fly simulator. And the woman was not improving. But after 3 or 4 sessions, or more, I don't know, she said that she was afraid to fly. So my friend was not reinforcing the patient. My friend was punishing the patient every time she got the criteria. So there are not better or worse reinforcements or reinforcers. There are only the right ones for each case. And these two approaches, one is the informative capacity of the value or reinforcement is based on the information capacity, and the other one is the ability to motivate. There are some authors that state that there is not studies that probe the effectiveness of continuous feedback, such as video game. So because this is too complex, and the patient is unable to integrate what is feedback and what is not. And these authors are supporting the idea of such Estes and Verden, that the effect of reinforcers in human conditioning are attributable to information value. And for example, they use, I saw several studies showing, for example, as reinforcers, a needle moving to the right side when the patient is getting the criteria, or moving to the left side when the patient is not getting the criteria, or a lighting when the patient is getting it, or turning off when it is not, he is not getting the criteria. But so at this point, we ran this study enhancing the effects of neurofeedback training, the motivational value of reinforcers. We recruit 115 subjects, I think, and we divide the sample in 3 groups or subgroups. A group who would receive real neurofeedback, and they could select their reinforcers. Another group will receive some neurofeedback, but they could also select their reinforcers. And the other group had real neurofeedback, but they were imposed the reinforcer. We measured the SMR before the experiment. We ran a SMR session for everyone with their condition, real neurofeedback, placebo, selecting the reinforcer, or real neurofeedback, but with a imposed reinforcer. And we measure after the session the SMR. And we also measure the quality they gave to the reinforcer, because someone in the selected reinforcer group don't like the reinforcer he or she chose. So we measure it, and someone in the imposed reinforcer group could like the reinforcer he or she was using. So we try to control it with measuring the quality of the reinforcer. The imposed reinforcer was this video game. Is based on Brainmaster Brain Avatar software. This is a pod where there are several balls, and when you get the criteria, more new balls appear, and when you don't get the criteria, some of them could disappear. It is really boring, so we use it. And for the selected reinforcers group, we said, okay, you can select a video game, a movie, or whatever you want, and we can use. And 100% of them select movies. Everyone a movie that he or she liked. So, and the assessment of the quality of the reinforcer was done through a visual analog scale, being 0, very poor quality of the reinforcer, I don't like this reinforcer, or 0 to 10, being 10 the best quality. I loved this reinforcer you used. Okay, and sorry, and what happened? Okay, the first result was that the real neurofeedback group got some changes in SMR versus placebo group that didn't get any change or any statistically significant change. But when we go into the subgroup imposed reinforcer or selected reinforcer, we found it. We found just statistically significant changes in the group that select the reinforcer, but they also rate as high value the reinforcer. It didn't happen in the group that was imposed. They received the imposed reinforcer, and they also rate high the value of reinforcer. So once one could think, okay, if you liked the reinforcer, it is as if you select it, because the point here is to have a good quality, a good amazing reinforcer. But no, they didn't change. Just the group that rate the reinforcer as high value, and also they select the reinforcer. It seems to be that the quality of reinforcer is not enough. You need also the feeling of control, the locus of control of the reinforcement. And our results were in the line with previous studies, with, for example, Fisher, Magnum, and all, that state that rewards or reinforcement that are more relevant to the subject generates greater learning and motivational condition, producing higher response rates. And coming back to the human versus animal reinforcement and so on, okay, in human conditioning, maybe the social conditioning and so on could work with informational reinforcement, but the signals of the brain are more like animal reinforcement, is more in this line. So the physiological signals are more similar to the things we do when we are researching with the animals. So it could be the reason why we need motivational reinforcers. And in the other hand, it seemed that the internal locus of control of the reinforcement, because just the group that select change the SMR and motivation, play an important role in the neurofeedback efficacy. So also secondary reinforcers and so on. But it seems to be that you need motivational reinforcers and also the feeling of control. One of these factors all by itself is not enough. And it is important to note that is inform is not to reinforce. And if we are running operant conditioning, we need to reinforce. And to inform could work, but maybe in another setting, in a social setting, or in another kind of intervention. But in our intervention, I think we need to reinforce. So to inform is not to reinforce. I hope you understand me, and thank you very much for your attention. If you want, you can ask a question or whatever.
Beautiful. We're going to get everybody unmuted. That takes just a moment. Richard or Aaron will get folks unmuted, and then we'll see if people have any questions. What's interesting to me, it's a great presentation, and it fits this model that if you're paying attention to NewMind and its software that Richard and the team have developed, and this follows beautifully like a functional neurofeedback. A lot of the information you were talking about, individualized treatment and so forth, really fits that model beautifully. So I thought it was really interesting and useful information for us.
I would applaud you tremendously, because you are concentrating on issues that have been blocking research that, and you made that point, researchers are not engaged in the field as a clinician. They can't understand the subtle issues, and they think that just doing a literature review is enough to make them an expert. And that is so much the problem. And you also outlined the details of all the problems conceptually, not all of them, but the majority of them, in doing research on neurofeedback in a way that I haven't heard anybody else address them. And it's just fantastic that you're taking a fine-grained look and doing it in a way that's constructive rather than destructive. You're finding, you're looking at the between the lines, so to speak. You're looking at why doesn't the research agree on so many projects, and we have such a complex thing to study. There are almost an infinite number of variables to feeding into it. It's a complex linear system, and so we have attention problems, and you get 5 different maps because hundreds of things can cause a problem with attention. And then we're trying to justify the word ADHD when it may be the word that's wrong, the category that's wrong, and not the brain maps. And issues. There's so many issues like that, and you have successfully itemized a lot of them. I've heard nobody do that before. I think it's fantastic.
Yeah. Sometimes it could be that the clinical level is not correct. I received a lot of patients diagnosed of ADHD, but when you analyze the EEG or QEEG, you think it seems like anxiety. I think it is anxiety, and why not? Anxiety can produce attentional problems, and what I tell families and patients is, okay, outside you are a ADHD patient, but inside you are an anxiety patient. So we will work in this direction. In anxiety, inside. Outside, we will see, but inside we will try to modify it.
Yeah, and that's so important. And the issues of reinforcement and how reinforcement differs and the way it's presented. I think you're right on. There, you have so much accurate issues to research. It's wonderful. I hope you have a good research team and you're well funded.
Yeah, and yeah.
I would suggest doing a GoFundMe with the neurofeedback community at large to support your quality research.
Yeah.
Yeah, this was a brilliant. I agree with everything Richard said. It was brilliant. I found myself wishing you were around 25 years ago.
Yeah, exactly. And in the neighborhood so we could talk about it.
You might also try applying for some funds through FNNR. You know, they do have some small grant fund programs. You can try them as well.
Yeah.
We have also a problem with when I try to present neurofeedback efficacy to other scientists coming from other related fields. The problem is, okay, but what about the double-blind, controlled, random trials? Okay, but what about double-blind, randomized, and blah 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 studies in surgery? So, and you cannot say that surgery is not good to solve your appendicitis. So, but the gold standard is double blind and control of variables and all of this stuff. But
yes,
in our field, we are talking about a procedure. Neurofeedback is a procedure. It's not a treatment like a pill. Then
Well,
we need other methods to check the
yes.
efficacy.
Yeah, that we worship at the temple of double-blind, randomized, controlled and the control is a fantasy. Somebody else said it first, but you can always confront them with the fact that there are no randomized double-blind studies that prove that parachutes are effective.
My favorite one.
Yeah, good example.
RCT designs, the first thing you learn in graduate school, hopefully, if you have a good professor, that you have to match the variable of interest to the design, and designs vary depending on what you're interested. You cannot use research methodologies in physics, in anthropology, or sociology. You have to, because the variable you're measuring, the complexity of the variable forces you to alter the design, and they never take that into account because a lot of them don't know the epistemology of science or really understand scientific methodology, and that's where you have to meet them, is challenge them at that level. Which you, in a way, you're doing here, which is fantastic.
Yeah, we have another problem at the university. I think I'm working at the university, but universities, I'm not sure in the States, but in Spain, universities become papers factories. So,
Yes.
so it doesn't matter if you are trying to check the efficacy of treatment today and to refuse this treatment tomorrow, but you will. The important thing for you, because your salary depends on your production, is to produce more papers. So you are not super engaged in the field you are trying to. Well, I'm generalizing. I know it is not totally
You are, but a famous professor at MIT says everybody in MIT knows the best research is being done in the garages around the university and not the university itself.
Because otherwise the university would own the results.
Yeah. Yeah. Well, this has been fabulous. You did a wonderful job. Your English was fine. I understood it all.
Yeah,
very
excellent.
good presentation. Thank you so much for doing this, and Rob for setting it up.
Excellent presentation, Dr. Perez. Thank you. Thank you.
Thank you very much.
So appreciate it.
Ruben, we'll let you know when it's posted. We'll be in touch. Thank you so much again, as you've heard. Great job. Easy to understand. Great information. We thank you.
Thank you.
Hey, everybody. We'll see you Monday night. Bye-bye.
Bye-bye.